As a way of introducing our next topic and to go into the workshop, the topic is to talk about whooping cough and HPV. If you remember, we introduced HPV as a cancer-preventing vaccine, not as a sexual health issue, because it's pretty controversial. Remember that we started off vaccinating girls only and then introduced boys, and then realised for obvious reasons that it's better to vaccinate everyone. And then we've gone to a 9-valent, so the 4, or there was a 2 available, for those of you who remember, and then it became a 4. So the 4 was a standard, and now there's 9 serotypes that are actually covered. So it's an amazing change. And then the flow-on benefits. Australia is one of the first places to eliminate cervical cancer. We've now moved to a 5-year self-test rather than a 2-year check with a doctor, with all its subsequent challenges that mean maybe women's health is potentially not as well supported because it's a 5-year cycle, not a 2-year cycle. So lots of interesting changes, but we've got to make sure that we vaccinate everyone with HPV, and we've got to make sure that we still get a whooping cough coverage. And in the pipeline, we've heard there's a whooping cough only vaccine probably 3 or 4 years away. I think Singapore and Thailand, I think, have got it. So for the moment, though, it comes packaged with a painful tetanus injection that may alter it. So to throw all of the challenges out, it's a great pleasure that I've got Catherine Keil, nurse practitioner, founder of the Travel Health Immunisation Clinic, to throw out the ideas, lay down the challenge, and help us work out how do we lift vaccination rates in those pesky adolescents, get them off the screen.
Thank you. That's a very long runway. You just don't want to fall over. How is everybody? This is the hardest session because it's after lunch and everybody's a little bit sleepy. So if you want to move around, feel free. I'm more than happy interactive sessions. So thank you, Immunisation Coalition, for inviting me to present on HPV and pertussis. And we're moving on. So we've talked about children. We've talked about the over 65s. Now we're going to talk about the beautiful group of adolescents. Who's got adolescents or teenagers at home? Okay, I'm going to pick your brains a little bit later. Okay, so this is my conflict of interest. I have received an honorarium to present today. Can everybody hear me okay? Yep. Great, so by the end of this session, you should be able to interpret current vaccination coverage for pertussis and HPV, recognise the consequences of under-vaccination in this age group, and analyse key barriers to vaccination against these diseases, and apply practical evidence-based strategies to improve vaccine uptake. Okay, so before we start, are there anybody in the room that administer school vaccines? Excellent. So I'll need your input later on. So just as a summary, as we should all be aware, pertussis, commonly known as whooping cough, is a disease of the respiratory tract, and it's highly infectious in unvaccinated people in Australia. And in Australia, we get epidemics usually every 3 to 4 years. Now we have the triple antigen of Adacel and Boostrix, and we usually administer this in year 7 in high schools between the ages of 11 to 13 years. Now, as we are all should be aware, adolescents need a booster dose because their pertussis immunity wanes after their childhood dose at 4 years of age. So it's really important, this booster, to maintain their immunity into adulthood. Now, as we should be aware, the vaccine is funded through the NIP. Now, moving on to the HPV, there are several types of human papillomavirus, or HPV, and people with persistent HPV infection are at risk of developing HPV-associated cancers. And obviously, we're aware of cervical cancer, but also we have obviously anus, mouth, and throat cancers. And adolescents and young adults are recommended to receive HPV vaccine, Gardasil 9, from 9 years of age and onwards. but the optimal age of this vaccination is around 12 to 13 years prior to exposure, hopefully, from HPV in the year 7 of high school. Now, as you should be aware from the immunisation handbook, people who have not received HPV vaccine by 14 years of age can still receive the vaccine up to the 25 years of age. But it should be really most effective before they're sexually active. And now we've moved on to our 1-dose schedule. Now, HPV can be considered in children aged less than 9 years of age. For example, if they've had history of sexual abuse or been diagnosed with a sexual transmitted disease. A subsequent dose should be given as routinely recommended after 9 years of age. So they need 2 dosage. Still awake? Cool. So we're going to look at some stats first. So firstly, HPV. Again, this is taken from NCRS. This is from the 2024 report on vaccination coverage in Australia, and this will be published later in 2025. Now, they've identified greater drops in vaccination coverage in adolescents compared with children. So teenagers aren't getting the vaccines. The percentage of adolescents receiving at least 1 dose of human papillomavirus by 15 years of age has continued to decrease, with the greatest decline seen between 2023 and 2024. So overall, 2 out of 10 adolescents have not received their human papillomavirus vaccine by the age of 15. And it's worse for First Nations adolescents. So among First Nation adolescents, 76.7% of girls and only 69.2% of boys have received at least 1 dose of HPV vaccine before their 15th birthday. And that is down from 2023. So moving on to pertussis, again, this is from NCRS, but from the coverage report from 2023. And it assesses a wide range of year-wide birth cohorts, and overall 73.9% of adolescents turning 13 years of age in 2023 have received an adolescence dose of the triple antigen by the end of the year of 2023. So coverage has increased with age. So by the time they turn 14, it has increased to 79.8% and 85.5% by the time they turn to 15 years of age. So the proportion of teens who have not received their adolescence dose of DTPA in the year they turn 15 has decreased from 87.3% in 2021 to 86.9% in 2022 to 85.5% in 2023. So obviously everything's decreasing, and that decrease is even greater in First Nations adolescents. So this is a little bit, I found this graph quite interesting. This is a little bit more stats from the NCRS annual immunisation coverage report in 2023. And as we know, in year 7 in high school, we give the triple antigen and Gardasil 9 on the same visit. And this is a composite measure graph, and it shows a receipt of both an HPV vaccine dose and an adolescent dose of the triple antigen by the end of the year in 2023. And as we can see, we're decreasing year by year. So coverage in 2023 varied within state or territory, ranging from 7.6% in the Northern Territories to 85.1% in ACT. ACT always scores high. It's full of politicians. Okay, and this is just looking at First Nations. Is this the First Nations? Yeah, people. And this just this is showing the HPV overall in First Nations people. And I find these results really quite terrifying, really, because if we look at state and territory, we're seeing 83.5% in New South Wales, but only 63% in South Australia, Rod. That's no good. All right, so that's the stats. We're not vaccinating adolescents as much as we would like to. Okay. So it's decreasing in Australia, but the figures are comparable to similar other high income countries such as the UK and US. So everybody's really in the same boat. So modelling indicates that sustained coverage of at least 80% is required in a both sex program to eventually achieve elimination of targeted HPV types in this population. So the downward trend with coverage in some subpopulations below 80% is concerning. So in order for us to reach and maintain our goals, such as for the cervical cancer elimination program in 2030, we need to commit and we need to get higher coverage levels. So efforts to address decline and improve HPV and DTPA vaccination coverage across all eligible First Nations age groups are crucial, given that there's much higher rates of cervical cancer in Indigenous women. So as everyone in the room is aware, under-vaccination in adolescence can cause issues for health risks, including disease outbreak, long-term health complications, and the strain on healthcare systems. And I'm just going to go through each of these and explain it a little bit more in detail. So vaccine-preventable diseases such as pertussis are resurging globally due to under-vaccination, as we have faced delaying or missing vaccination, and obviously exposes children and adolescents to the serious risks and complications associated with multiple different vaccine-preventable diseases. So adolescents are particularly vulnerable in school and social settings where close contact facilitates transmission. Our herd immunity thresholds are compromised, allowing diseases to spread even among vaccinated individuals. While the decline has been modest, the downward trend is concerning. It leaves more teenagers and members of the wider community vulnerable to serious infectious diseases. We have long-term health impacts, and that's really related to HPV. We are aware of the cancers HPV can cause, and it's entirely preventable. Under-vaccination undermines decades of progress in reducing these risks. Social, economic, and community consequences. So school absenteeism and academic disruption due to getting ill can cause an effect. Strain on healthcare systems, we can see that during the COVID pandemic, and also amplification of health inequalities. And we've seen that through the stats in relation to our First Nations people. So I am going to go through a few things that it's been touched before, but I'm going to try to put it on a bit of an adolescent spin, okay? So as Ali explained earlier this morning, the National Vaccination Insights Project, and this was a collaboration between the Murdoch Children's Research Institute, NCIRS, and the University of Sydney's Social and Behavioural Insights and Immunisation Research Group. And it was established to actively investigate and report on vaccination barriers and drivers. And it's really great work. And its aim was to inform targeted strategies to improve vaccination rates across diverse populations in Australia. And I'm going to just summarise the key findings of this in regards to adolescence, okay? So the key barriers to vaccination I'm going to go through, but mainly as we discussed already, it's in regards to acceptance and access issues. And this is a nice summary from the findings, just summarising what they found. So first of all, let's go through knowledge and awareness barriers. So low awareness among adolescents and parents about the diseases prevented, especially HPV vaccination-related cancers. I'm sure we've all had consultations where parents have said, "Oh, my child's not sexually active, they need the HPV vaccination. I don't want to talk about that. Misconceptions about vaccine safety, side effects, or is it really required for boys? That's always one. And limited understanding that the triple antigen boosters are still needed in adolescence despite childhood vaccination. Access and convenience barriers, and we've discussed this extensively already. Most obviously, these vaccines are in a school-based program. It's excellent. I have vaccinated many a teenager in schools, but there are some limitations. For example, missed vaccination days, absent students hiding in toilets trying not to get the vaccinations, inadequate follow-up for missed doses, issues with consent forms, homeschooled adolescents. Although extended school closures and consequent disruption to school vaccination programs at the height of the pandemic likely played a role in reduced uptake, these occurred almost exclusively in Victoria and New South Wales, so they can't fully explain the ongoing drop in adolescent vaccination coverage across the country. So, if vaccination day was missed at school, where does the teenager go? Quite often to primary care centres. There can be geographical or logistical barriers, especially in rural and remote areas with limited healthcare access. Clinic hours that conflict with school or work schedules, appointments availability or accessibility, and cost. And we've spoken about that in regards to not only consult cost, but also travel costs. There's social, cultural, and attitudinal barriers to these vaccinations. As already discussed, parental hesitancy driven by misinformation, distrust of pharmaceutical companies, and too much TikTok as well. Cultural or religious beliefs opposing vaccination or discussing sexual transmitted infections with 12 or 13-year-olds, and peer influence and social norms. Teens may perceive vaccination as unnecessary or uncool. We have healthcare system barriers. Some clinicians, and I'm sure they're not in this room, may not strongly promote adolescent vaccinations. We have inadequate reminder recall systems if vaccines are missed. And then there's policy and structural barriers, varying vaccination policies between states or schools, inadequate consents from parents, caregivers has an impact on vaccine uptake. And insufficient funding or staffing for school-based, some, not all, school-based immunisation programs. For example, is there an information evening for parents and students? Have staff been trained in answering the questions about vaccination? And this is really important if any of you have got teenagers. Psychological barriers. How many teenagers absolutely hate having vaccinations? Okay, so I specialize in needle phobic children and teenagers, but this is a really big barrier for adolescents, the sheer anxiety over having a needle, and often at school in front of your friends. Also, adolescents perceive low risks. They don't feel they're personally at risk for HPV infection or pertussis. They feel they're invincible. Everybody still awake? Great. Okay. Now let's look at the positives. Let's look at the practical strategies to get these adolescents vaccinated. Again, I'm going to summarize 6 areas, which I will discuss in turn. So please remember this list isn't absolute. And if anyone has further ideas or strategies, please share. I'm really interested to hear about the nurses over there who give these vaccinations. So we need to strengthen our existing and effective platform for adolescents in regards to school-based immunisation programs. And just a few ideas. Automatic catch-up sessions. We're only giving 1 Gardasil 9 or HPV vaccination now. We used to give 2, so there was an opportunity for catch-up of the triple antigen at that time. Do we need consent simplifications? Parents with teenagers here, what do you find in their school bags at the end of the term? You find lots of things. Quite often there's a consent form in there that's never been given to parents. We need to encourage school nurses and teachers to promote vaccine awareness and reminders, and we need to ensure equitable delivery to remote, Indigenous and disadvantaged communities. And we really need to optimize that school communication channel, their newsletters, their texts, their apps, really to promote upcoming clinics. We need to educate and communicate more to the adolescent and caregiver. There is considerable evidence supporting the effectiveness of communication in person, by phone, or in writing to increase vaccination. Jill Normal and Old study, which was published in 2022, is an example of such research, and the reference is at the end of these slides. And this is a really good example of an education program I found. It's the Australian Cervical Cancer Foundation awareness program called HPV in Me, which empowers high school students with preventative strategies to reduce the health risks associated with the human papillomavirus. So they need to be aware of such education. And it's free, it's a digital program, easy access. We've spoken about this already, but essentially a strong healthcare provider recommendation is one of the most influential factors in vaccine acceptance. Everyone in this room needs to provide a strong, consistent recommendation, use every visit as a vaccination opportunity, and check air, as life is busy and teenagers and parents forget about vaccines. They don't realize their child has missed a vaccination. So every opportunity, check air and see if they're up to date. So what can primary care centres do? So as already discussed, we need strong provider recommendation, clear, confident, transparent vaccine recommendations from healthcare providers. We all have a role. Now, in regards to our nurses, pharmacists, GPs, we all have a role too. Should we administer vaccines without direct doctor's orders? I know that there's SDOs, standard drug orders, but this is an area I feel very strongly about. From my accent, you know I'm British, so I did my training in the UK, and nurses and now pharmacists do all the vaccinations, okay? So just like the great work pharmacists are doing, administering vaccinations, we need to encourage nurse practitioners, nurse immunisers, to really get on board. Now, example is my own clinic in the Barossa in South Australia, where I work with local medical centres to assist freeing up GP appointments and offer catch-up vaccinations. We need to let nurse immunisers work to their full scope of practice. They should really have their own Medicare item number for vaccinations. That's getting a little bit political. We need increased accessibility and appointments. We need an allied health-centric approach to vaccination, not a turf war. And provider incentives. We need to encourage healthcare providers to prioritise vaccination through policy incentives to reduce costs to the patient, such as the bulk billing incentive. We need to adapt programmes and policies. We need to think out the box. We also need to improve access and convenience for the adolescents. Examples are mobile clinics, late night appointments, Saturday weekend appointments to catch up on their missed vaccination. We need to support communities to develop innovative approaches to address barriers to vaccination and improve access to all vaccines. Should be priorities across all age groups. So you could apply this to all vaccinations. And really important, we need to build trust and community engagement. We need to really focus on that disease prevention and protection, not risk or fear messaging. So we need to tailor messaging and address specific concerns of different communities. Examples that's already been highlighted are the Sharing Knowledge About Immunisation website, an excellent resource which provides the patient with evidence-based information, helps answer common questions and supports conversations. Healthcare professionals can also use it. So resources alone, of course, cannot ensure high immunisation rates if the public distrusts the quality, safety or effectiveness of vaccine. Gaining trust has become difficult post-COVID-19, as we're all aware. We need trusted messengers, and we need to really utilise healthcare providers, community leaders and influencers to promote vaccination. We need to combat misinformation with targeted health education. I'm not mentioning United States in regards to this. We need more public health campaigns, altering the informational environment to afford greater power to accurate science-based messages, which would assist with patients' concerns. There is a need for ongoing disease-specific information direct to the general public. They need to be better informed of the harm infectious diseases and understand the benefit of vaccination, rather than reading and listening to misinformation and scare tactics. Obviously, we also need multilingual and accessible information for all. And in regards to policy and system level support, we need to obviously maintain our national immunisation registers, our AIR for tracking and recall, which we should all be doing. Maybe we need to have opt-out consent models where permitted instead of opt-in. And maybe use incentives or recognition programs for schools or providers achieving high coverage, just like we're seeing in residential and nursing homes from the 1st of November. We need to ensure consistent national guidelines and adequate funding for school immunisation teams. And again, that's from the National Vaccination Insight Project. I'm nearly finished. Just a summary of what I've been talking about. I really encourage everyone to have a read. And this is from a study, again, references at the end of my presentation, which I'm sure you have all access to. Just giving you a few different examples of how we can increase uptake in adolescence. And I'm going to skim over this. This is obviously, we've talked about this, talking about the 6 key priority of areas, which is really useful. And I did read this this week. Atagi has written a statement on immunisations as well, which touches about adolescence. So I implore you all to have a read of that. We've mentioned the 6 priority areas already. So I'm just going to skim over that because we've already mentioned it. So in summary, as we are all aware, missing or delaying vaccines risks serious disease. Understanding and addressing barriers to vaccination is a priority across all age groups, including adolescents. Don't forget about them. Accessibility and a clear, trusted healthcare recommendation is so important in increasing vaccine uptake for adolescent vaccinations. That's my references. I'm happy to answer any questions.
So thank you. So our format, as we've been talking about before, is that for people in the room, we go into the workshop. We've got one question that came online, so maybe you could answer that, and then we'll have the online people remember that you have to do your workshops at home. You can leave and stay logged in because the next formal presentation will be 2:40 Australian Eastern Standard Time, so it's not daylight saving time. So remember, it's based on what the time is. So we'll have another presentation at 2:40. And for those of you who are here, if we do the workshop similar to what we've had before. But one question online talks about a 29-year-old who's had a vaccine and she came up positive with one of her smears or one of her self-tests. What's your suggestion, recommendation? So she had her vaccine in year 7 and then she's 29 and she's come up positive?
I would say you would have to find out what HPV she's come up positive, as in.
Yeah, so she was, yeah. So I think that's a clinical question where the person looking after her, it's not the positive test, it's the persistence of the positive test that's associated with the malignancy. And that's one of the important things to remember from a clinical point of view is that you can have an infection, but it's as long as you get rid of it that you don't end up with your cancer risk. It's a bit like sun. You can go out, but don't spend all your time in the sun. So don't spend all your time with a positive test. So do you want to just quickly comment on that? Or question?
Sorry, I just had a question. And my question is around consent. So I know from immunising where I was in the school program down on the Gold Coast, we used to accept students consenting for themselves, and then obviously something happened, we no longer could, and yet they can consent for themselves going into a GP practice. I was speaking to a colleague down in Melbourne, they accept consent from the students themselves. And yet I was just speaking to the Brisbane ladies here, and they can't. So some consistency around the guidelines on consent may actually improve the rates of vaccination for HPV. And I was just wondering what thoughts there might be on that.
Can I just start with that? Like I said, when we, back in the 90s, when we were first looking at it, national program, it was a 500-page document that we started working on, and consent is a complicated issue. And there's anomalies like a 15 or 14-year-old pregnant mother can give advice and consent about her child, but she can't give consent for her own appendix or surgical procedure. So there's some anomalies and there's some discretion, and it depends on where you come from. So that's complicated, and it's always going to be.
It's always going to be complicated. So I'm from SA. I can only comment on SA. And when we did our program, if they were 15 years or younger, they had to have a parent or guardian consent. We would not vaccinate them. If they were 16, they can consent. It was a pain because in the clinics on that day, you've got 200 kids lined up, ready to be vaccinated, and the signature is missing. So be phoning parents to get a verbal. 2 of you would take a verbal. So yeah, consent is a big factor, and we should do more work on it.
And just in practical terms, for the online will be coming off. So therefore, the workshop is what we need to get through, but we can ask and continue with questions because it's now us as a group. So online is off. So I'm happy to continue with the questions. And then, but remember, there's a worksheet in front of you. So as you listen to these questions, think about the workshop, and then we'll move into that and go through that. So continue the question then.
My query is just the 29-year-old you mentioned before. I know of a lot of people working within women's health who are actually then getting the women to get re-immunised with the Gardasil 9 now, not just.
Okay. I didn't know that. I'd be really
And
interested to learn about
there's no clinical reason why you can't.
Yeah.
But
Exactly.
the risk of cancer is the persistence of the and the whole screening program is based on the fact it's the persistence of the virus, not necessarily. And if it's a non-16, non-18, then it's a less risk, but it's a persistence. So if you repeat it, so that goes back to the.
There's a lot of 20 plus year olds who were immunised with the initial types of Gardasil, and they're not covered for the other subgroups.
That will be a private vaccine. They would have to pay for that vaccination, obviously.
Yeah.
So that's a very small area. I don't think we see that a lot in primary care. But yeah, that's maybe you refer to the specialists, the consultants, and ask their advice.
It's the persistence of the.
Hi, Sarah, Brisbane-based GP. Just to answer your questions, 70% of the cervical cancers are caused by HPV 16 and 18, which is covered in Gardasil 4. The Gardasil 9 has the additional 5, 31, 33, 45, 52, 58, but that only gives you an additional maybe 23% protection. So it's the cost risk benefit because it's not cheap.
In the original studies, when CSL and GSK brought out their vaccines, GSK had a 2-valent, CSL Seqirus had their 4-valent. The incidence of infections was still prevalent up to 55. So the whole controversy about why do we stop at 26, where you still come in contact with the virus later, but it's not persisting. So you've got antibodies, doesn't mean you don't get an infection, but you get rid of the infection, and that's what provides protection. So, and this was the controversy about when boys get it, getting it isn't the issue, it's as long as you get rid of it. So having the virus isn't the cancer producing thing, it's the ability, so making antibodies so you can actually get rid of it. So that's why it becomes a follow-up and a cervical screening and management and testing and specifically. So it's about the persistence of the infection.
I'm very amazed, Sarah. That was amazing stats you just reeled off there. So well done. You did well.
So I've got some questions here too. coming.
Oh, sorry. No, sorry, didn't.
Yeah.
Taylor's oldest child. Thank you. Loved every part of that. And it's, I guess, I feel like this is the topic's coming. This awareness is quite topical at the
Yes,
moment. So
it is,
thank you. The whole time thinking, well, how can we do this? And I'm thinking campaign wise, when they're coming to get their flu shot, do you check their air? But then I'm thinking, well, they're probably going to be the pro-vac, so I'm doing all of that. I'm wondering, when I'm thinking pharmacy, but of course, when you're prescribing, say, an oral contraceptive or something, you're already starting to have those conversations anyway. Is there thoughts around campaigns that we could all together do some sort of campaign where it's, hey, I noticed that you're in this space, how,
Yeah,
how do
I
we have
think
that?
there's always need for campaigns wherever. So when I have children, or not children, they're 12 and they're doing catch up 13, 14-year-olds, I often say, look, I'm going to get really embarrassing now and I'm going to talk in front of the parent and you can see them going red and I'm trying to we need to talk about this. I think there's need to be more promotion in schools. I think education, so I used to work at a council in SA and there used to be information evenings like a few weeks before we actually gave the vaccines for parents to ask their questions. There just needs to be more talk about it. It's not closed behind door because it's, it's sexual health kind of thing. And we're worried our teenager are only 12 or 13 and we're talking about sexual health. So yeah, campaigns, definitely. Watch this space. There's things.
Rollout in Australia had to be put under the banner of a cancer development program, and there was a lot of pushback from Catholic schools, and we reminded them that if they wanted to have their good Catholic children when they're 20s, it was still worth having the vaccine because it wasn't about sexual activity now, it's about cancer prevention. But yeah.
Can I just ask a medical question that I probably should know the answer to, but I don't? How much protection does Gardasil give against genital warts? Just good old-fashioned genital warts? Because
It does give, but I don't know the stats. Do you know the stats, right? But it
I'm
does.
looking over at Sarah, but
Sarah,
yeah, it's
look at
probably
over to you, Sarah.
It does,
27%?
I think it's higher
but
than
the
that.
percentage.
Higher. So for HPV 6 and 11 is covered in the vaccine, and I believe it's over 90, but
Yeah.
it might even be 99. I think for a lot of the GPs in the room that are willing to admit how old they are, the difference with what we see, like the condyloma acuminata, we don't. Only in the ones that haven't received the
And there's some
vaccine.
cross protection.
I was just thinking, is that a selling point to teenage boys?
Boys,
They don't care about cervical
I
cancer,
totally use that
but
as a
they
selling
don't want to
point
get
to
genital
people.
warts. Yeah.
I speak about that. Yeah, definitely.
Could
So
I?
we're moving.
Could I add one
Yeah,
more
go.
comment? A little bit off topic, but about 1 to 3% of the Year 7 students are probably not enrolled in traditional schools. So homeschool for distance, online, whether they be rural, gifted, TUI, athletics, people being accelerated. So I think it's a group beyond the scope and time of what we've got available for discussion, but not to forget this small group of cohorts. There's a 14-year-old that I met recently who's enrolled in second year university maths and physics studies. They're obviously the outliers and not the typical ones that we're thinking of, but there's a small group that we need to
But
consider.
that's a group where you're going to see in primary care, needle phobic as well. I would add to that group. So majority is school based, but that's really important because I do see a lot of homeschool kids as well.
So we're moving to our workshop.
One more thing I wanted to say was, and something that didn't get covered with all of that is, you mentioned about doing catch-ups and the remit to try and get them. The issue that we have is around funding as well.
Yeah.
We're only covered, we do year 7s and we can only catch up year 8. So there will be a number of year 10s that we see and we check air as they go through. And we're not allowed to actually, or we don't get the funding to be able to immunise them. So if that came up, we could actually then offer that to those grade 10s and 11s that we have missed in grade 7.
The only concern about that is I know if you're going in for a year 10 vaccines and you got, in SA we give meningococcal B and ACWY in year 10, you then got to take your vaccines.
We do that already.
Do you do that?
We actually do
don't you?
catch-ups for all the
That's
children that we
great.
missed.
Well
So
done.
any children that we miss, we offer a catch-up clinic in
Yeah.
July and then we do another one in December.
I totally
And
agree.
we do them at the schools as we go around. We're doing
That's
them
really
now.
good.
Is that
Yeah.
Queensland?
That's Brisbane.
Yeah,
So-
that's,
so
but that's
it's
Brisbane.
State funding.
So we only, yeah, it's all state
like
funded.
NB as
But
well.
we actually catch up any that we've missed on the first 2 rounds. We do them now, and then we offer catch-up clinic again at our branches.
yeah, well done you. Keep doing
And
the good
that's
work.
why it's good to have an air. So since 2016, just the amazing. So we get a chance to quiz the government on, we've got air, but we want it to work 120%, not just to give us 60% of the solution. So it's a major step forward in Australia that since 2016, we've had a national immunisation register.